Welcome to the March 2021 RUSI lecture. I'm the President of RUSI New South Wales. It's my pleasure to both welcome you and to introduce our guest lecturer. This year we're deliberately running a series on improving resilience with a Defence and Security Studies emphasis. And I'm delighted that in March we're able to get the Chief Medical Officer of Western Australia, who has led the West Australian response to resilience, sharing his ideas with us on leadership and improving resilience, and in effect, what have we learnt from the COVID experience. Now, Dr. Andy Robertson, CSC, is both a very senior medical officer in West Australian Department of Health, and Andy is also a Commodore in the Royal Australian Navy. I'll just look briefly at a couple of key points of Andy and share them with you. Firstly, Andrew served in the Navy and is still a reservist from 1984 to 2003, 3 tours of Iraq, a Chief Biological Weapons Inspector with the United Nations Special Commissions. He remains in the active reserve. He's currently at the rank of Commodore, and he was the Director General of Navy Health Reserves until December 2019. Now, perhaps more in the role that Andy will speak to us, Andy has been the Chief Information Officer and the Chief Medical Officer of Western Australia, and in those roles he has led the West Australian response to the COVID-19 outbreak. We're very privileged to have a very senior person who has undertaken the responsibilities of Andy and with the senior positions of Andy, willing to share with us their personal views on leadership, improving resilience, and what we can learn from COVID. It is my real pleasure to introduce our March 2021 RUSI New South Wales lecturer, Dr. Andy Robertson, CSC, Royal Australian Navy, and Andy, as I've indicated, will share with us his understandings of the implications of COVID on leadership and in building resilience. Thank you, Andy, and over to you.
Good afternoon. I'm Commodore Andy Robertson. I'm very grateful to RUSI to allow me to do this presentation. I'm currently the Chief Health Officer within the West Australian Department of Health with responsibility for managing the pandemic within Western Australia. I'm going to put up some slides which will go into further detail about the main topic today, which is around leadership and resilience in a crisis. So the title of my talk is Life in the Time of Corona, which is obviously a reference to Gabriel Garcia Marquez's book, but it's really around leadership and resilience during a crisis. As you're well aware, coronaviruses have been with us since the beginning of last year. It's a small virus that is related to the SARS and MERS-CoV viruses, and this commonly occurs in bats and similar animals. We see a respiratory illness with fever, dry, non-productive cough, headaches, which can progress into pneumonia and in a small percentage of cases into death. There are no specific antiviral treatments. There have been some tried, but they don't work. And then what we've seen is the best thing is symptomatic management. The full vaccination is obviously now with us, and I'll talk about that further. So this disease was first described in Wuhan City in Hubei province of China. That were the first reports we saw at the end of December. By the 30th of January, it had been declared an outbreak of public health emergency of international concern, the PHEIC. And by the 1st of February, we'd imposed travel restrictions on China, and then that moved to Iran on the 1st of March. Now, the origins of the outbreak are actually quite interesting. Most of the claims are that it relates to wild virus that come from bats possibly horseshoe bats that some research had been done on, and a number of other viruses are similar, and that it actually came from some of the wet markets where these animals were sold. Now, I think that has now been excluded by some of the studies in that area, but it still remains unsure as to where it actually has come from. Also within Wuhan City is the Wuhan Institute of Virology. We know that it was doing research on coronaviruses, including 3 similar viruses, and there's also reports that in November of 2019, a number of people became unwell in that institute, which may have been related to this coronavirus. There's also concern that they were doing what's known as gain of function research, which is really, what kind of changes need to be made to the virus to allow it to become a pandemic. But there was also some speculation that it may have been due to vaccine. They may have been doing vaccine development. It's still unsure, but this possibly could have led to an accidental leak or release of the virus from this institute. But I think there's still many unanswered questions in this area. What we saw subsequent to that was obviously the spread of the virus. This gives an idea, starting out obviously in China and Spain, Portugal. It progressed throughout the world into the US, and you get an idea of where it is by the 14th of April. And this is the global situation now. As you can see from this, there are some major issues still, particularly in the United States, Brazil, parts of Europe, and other parts of Southeast Asia and India. The number of cases continues to accumulate. As you see, again, the United States, France, UK, Brazil, Italy are all some of the worst off countries around the world. And as of yesterday, as of the 27th of March, there'd been over 126 million cases, 2.77 million deaths. In Australia, just over 29,000 with 900 deaths, and in WA, 934 cases with 9 deaths. So it's an extensive disease that has impacted on all of us. This is just a quick slide showing where we were at with COVID-19 in Australia. We obviously had the first wave that occurred towards the end of March into April, then the second wave, which largely occurred with a few other cases in other states, but largely in Victoria. And we've subsequently have had no further waves, but that has been over the summer period. And this highlights what we see is the second wave that occurred principally in Victoria. The Northern Territory at the bottom more reflects the use of Howard Springs for bringing back overseas repatriation people. So when I was looking at this around leadership in a crisis, and leadership and resilience in a crisis, there have been multiple texts on leadership, and there've been quite a lot on organisational leadership, quite a lot on military leadership, and I've obviously added a few sort of examples of those on this slide. But there's very limited guidance on leadership in a crisis, particularly a prolonged crisis. There's obviously in dealing with a short-term disaster, there are directions, and there's even less guidance on how to use public health leadership in a pandemic. At the end of the day, I'm a public health physician by training and a disaster medicine expert. So a couple of the public health objectives here are, how do we prevent unnecessary morbidity, mortality, and economic loss resulting directly from the disaster? But also, how do we actually make sure that our disaster relief efforts, if we mismanage them, don't make things worse? Also, as a public health physician, we want to minimise the risk to the community from any hazards, obviously identify those things that are likely to give rise to those hazards, optimise any activities that might reduce their risk. So these are our public health measures. Optimise activities to mitigate the impact of those emergencies. So what can we do to actually reduce the subsequent disease, and then obviously make sure we have sufficient staff. So if we look at crisis leadership going forward, there's a few things we need to look at. This is around crisis and leadership and resilience. Obviously, we need to frame the event first of all, and to do that, we need to look both inside and outside of the organisation. This is not just a health issue, it's a whole of government issue. We obviously have to be aware of unconscious bias. It's very easy to fall back on the familiar and the comfortable, and particularly in medicine, we know what to do in other outbreaks, but this is hardly the same. Ambiguity becomes a major issue. There were, particularly early on, very weak and conflicting signals. How bad was the disease? What did we need to do? And then there is a need to actually act with courage, often dealing with limited information and dealing with that ambiguity. Obviously, we need to listen to our critics, listen to the people who work with us to make sure that we are what we're doing is evidence-based and eminently makes sense, but we do have to have that courage to step out on occasion. And then there is that accessibility so people can get to us, and obviously that they then are able to follow our lead. I always like this quote from Field Marshal Helmuth von Moltke: "No plan of operation survives first contact with the enemy." That was from his book on strategy in 1871. And that's certainly what happened in this circumstance. So the COVID-19 situation rapidly evolved and quickly outran the pre-planned responses. We had the disaster response plans. We had extensive disaster response plans, including pandemic and respiratory illness disaster response plans. We had the legislation to do it, but we'd never used that legislation. We'd never used a state of emergency, certainly in my state. And my role as the Chief Health Officer of our State Health Incident Controller and the Director General of Health were quite unclear in the first instance. We knew what it said, and the plans helped us to actually set up, but it rapidly became obvious that we were going to have to work very closely with other agencies, particularly police, with national agencies, including Department of Health and Prime Minister and Cabinet, and that we had to have very good operational structures and people and a very clear intent as to where we were going to get through this. And we had to deal with a lack of preparedness. One of the issues we had early on was that we relied on, for our protective equipment, on just-in-time supplies. When all of a sudden those just-in-time supplies dried up because all of the world wanted protective equipment, we had to deal with that quickly and in an interesting role. And then there was the role is, what is my role? What is our role? And we had both an operational role to make this work, but also an advisory role to government. This just gives an idea of we were the lead agency. We obviously had to work with our health sector and our Premier and Cabinet to make sure this worked, and obviously with police as well. And that meant going through the Premier and Cabinet, but also to working with our Premier and the respective ministers. The legislation is outlined there, but it primarily in WA, it was under the Emergency Management Act and our Public Health Act. And we had to rapidly move to using our state hazard plans and our pandemic plans. So just to take you back, this is back in early March, so about a year ago. We only had 78 cases in Australia. We had one death in WA that had come from the Diamond Princess, or a person who'd come from the Diamond Princess, a couple of deaths in New South Wales. And the majority of the cases had a travel history from mainland China, and we're just starting to see cases coming in from Iran. And this gives you a quick idea of the rapid growth. So by the the beginning to mid-March, we knew we had a serious problem and that this was getting out of control. We'd already brought in some controls, as I said, on China and some of our border controls, but these escalated rapidly over that period. This is got to have a structure. This is the organisational structure, which shows me as the Hazard Management Agency and also as the Chief Health Officer, and then the various people reporting to me. And this was rapidly established. You have to remember, in context, SHIC, State Health Incident Coordination Centre, is a virtual organisation, is only created in time of disaster, but this had to become a full-time organisation. Nationally, a number of the legislation came in as well, including the Biosecurity Act and National Health Security Act, and we worked very closely through the Department of Health, particularly via probably now one of the better known committees in government, which is the Australian Health Protection Principal Committee. And the whole purpose of that committee was to bring all of the states and territory chief health officers together, the chief medical officer, defence, and a number of other agencies, and to actually try and coordinate an evidence-based response in Australia, and to get, to the degree we could, national consistency, including a national COVID-19 plan. And that actually worked remarkably well. It also benefited because obviously the national government listened to the advice that came from this committee, as did each of the states. But it wasn't just about the health aspects of it, it was also around the whole of government. Where were we going? What were the impacts likely to be? Not just on health, but on education, tourism, the economy. How did we deal from that from a whole of government point of view? But how do we also continue to maintain some of our critical services? We got very close with food supplies, water and fuel supplies at times. Obviously, you need to maintain essential government services like policing and fire and emergency, maintain health services, make sure the public knew what was going on, and then managing some of the public health measures like school distancing. And in the first wave, most jurisdictions, well, all jurisdictions in Australia, went into some form of lockdown, which included school closures. And there was a number of issues that came out of that from HR, workforce and travel, i.e. we basically ceased travelling. This gives you an idea of where we were at with our supplies now, which is good. But again, just to reiterate, at that stage, we were struggling. We were looking at supplies from all around the country. So we had to adjust and work very rapidly to actually acquire the sufficient supplies. The next part of the crisis leadership was that piece around thinking strategically. My role was, and I think the roles of most leaders in a crisis, is to really that big picture, long-term issues, to make sure that they are not lost in the operational frenzy. It was without a doubt frenetic at that time, but at the end of the day, we needed to get to a situation where we could bring our jurisdiction, our country, out of this pandemic going forward. We obviously needed to know what was going, and that relied on everything from the local news feeds to the information we got nationally. Need to be working with very clearly with teams, but also working up and down to ministers and managers. So it became very critical, more critical than any other event, to work very closely, not only with my health minister, but with the Premier and other key ministers. And then to have that overall strategy. Where were we going to go? So I've used a chess analogy here, but we're talking around the middle game. So in that first 12 months, when we knew we weren't going to have a vaccine, how do we actually get through that 12 months? And how do we get some form of recovery of the economy after the first wave? And what could we do? How could we ease the economy to actually allow for business to continue, allow events to continue, allow people to be able to go out and relax and spend money, basically. But we knew that that was only ever the middle game. It was around creating that situation where we could be well prepared when we went into the end game. Now, the end game was always around when could we actually get the population protected enough that we could start opening it up, not just to the country, but to the world. Now, one option was immunity through infection. That didn't work. The reality is we've seen a number of countries, including the UK and Sweden, try to do that. All they ended up with was with tens of thousands, if not more, people in hospital and tens of thousands of deaths. And if we look at Sweden, they still only had a small proportion, like 8%, who were protected after that. So vaccination rapidly became the only real feasible and viable option. And with the intention that if we can protect the large part of community, get some form of herd immunity, then this would go from being a pandemic disease to possibly an endemic disease, where we just had, it was similar to what we have with the flu generally. But to get there, we had to think strategically. Public health measures you'll be well aware of, the border controls, the hotel quarantine, and that was around managing our risks. Obviously, we had to boost up our tests and contact tracing, but we had to also impose restrictions to decrease the density of people in various venues, whether that was in businesses, whether it was in hospitality or other industries. But we also had to make sure that if it did become a major outbreak, we were actually prepared for it, both in our hospitals and the community. So this gives you an example. We set ourselves a target. We had about 120 ICU beds in WA when we first started out, and we set ourselves a target to get to 427 ICU beds. And this is just a list of all the equipment you need to do that, and a few other things. And we got there, but it obviously took a lot longer than we hoped, and fortunately we've never had to use it. So the third part of this is really around, second part was on the strategic planning. This was also, we had to look at how were we going to respond going forward. What kind of planning do we need to do now? And a lot of this was around the operational planning. How did we what we had to do a lot of modelling as to what that might mean. What happens if we get an outbreak in a prison? How do we model something in an aged care? And to do some of the red teaming, where we were looking at the worst case scenario planning and how we would do. And we did that at both a local and national level, and we also had a number of reviews that were looking at whether our planning was robust going forward. So just to give you an idea, this is some of the things we did beginning back in February last year. How do we set up our COVID clinics? What do we need to do to surge up our intensive care units? What do clinical guidelines look like? Can we use the private hospitals? What is the workforce? How do we expand that? And how do we triage if we get too many cases? But we also had to focus some of our plans going forward, and this gives you an idea of the kind of plans that we developed that were used to go forward. And on a national level, we very much were looking at, we got to a stage, particularly after the first wave and progressively throughout the year, where we actually realised that we didn't actually think initially that we could suppress this disease, but we were successful, and we remain highly successful in suppressing the disease and actually meeting a goal of no community transmission, i.e. we have no cases in our community. The only cases are coming in are those that are coming from overseas. So the next part about building this sort of leadership and resilience was really around that building of the resilience and adaptability. And particularly that became, developing that resilience and flexibility in our workforces, particularly around the ambiguity and complexity was critical. And we've seen, and I've certainly seen in my workforces, real maturing in these aspects, particularly around this whole point about how do you deal with ambiguity. Early on, we had conflicting messages on the disease. We didn't know what the likely effects were. We didn't know what the best ways to manage it were. There were lots of theories and not much evidence. We had to work closely with agencies like police, Premier and Cabinet, education, transport, other agencies that, while we'd had good relationships with, never to this extent. We obviously made mistakes on the way, but we did learn a lot of lessons about working together. We've actually had to deal with legislation that had never been applied before. And how do we use the states of emergency? What are the strengths of it? What are the weaknesses of it? And we had to be constantly evolving and flexible, accepting that we'd make mistakes at times, learning a lot of lessons from them and moving on. This is one of the slides I use a bit. For those who can't read it, it says mistakes. It could be that the purpose of your life is only to serve as a warning to others. That was always at the back of my mind, and hopefully I haven't proved to be too much of a warning. The other thing was this, the whole decision-making piece, and this is around leading in a crisis. We have to make multiple decisions, often very quickly and often on limited information, but generally based on the risk assessment. What is the risk of this? Is it medium, low, high? What evidence do we have for it? What do we understand about the limitations of that evidence? And to a degree, what is the risk appetite of the government and agencies? And that will vary and has varied between different government and different agencies. Obviously, we need to listen to our critics. They often can see things that we may be missing, and sometimes we're ahead of them. So that's, it works both ways. Obviously, part of a role in an executive leadership role is actually protecting your agencies, not from criticism, but protecting your agencies so they from micromanagement by other agencies or by our political hierarchy, and that allows our operational people to get on and do what they need to do. And then we have to deal with some of the operation decisions versus the health advice, and that can be from mundane to the surreal. I just added this. There's a small photo at the bottom about face painting. When you start getting asked on one day, whether we should close the borders, and on the next day, whether we should allow face painting, sometimes it gets a little surreal. As I've said, we need to make those decisions based on risk. And we also had to navigate the law. So for those who are aware, part of my role as the Chief Health Officer is as the regulator. So I got drawn into provide the health advice and the health position in the Palmer High Court case. So we had to provide that, and as you're aware, we were successful in the long term. But there was a range of issues that we had to deal with. Use of Rottnest Island for hotel quarantine. Should we allow schools to go back? Can we ease restrictions at a certain thing? What should we do with our border controls? Should they, at what stage do we ease them? What stage do we reapply them? We did quite a lot with the military forces, the local in WA, and I'll talk a little bit more about that. And then obviously dealing with crews and merchant ships, many of whom were infected. And so we had developed a lot of expertise in managing both infected cruise ships and merchant ships. And at the end of the day, I act as an advisor to my government, and provide health advice, and accept that there are obviously other broader context at bay, and we obviously need to be aware of that. So just to use an example of military forces, so we saw early on a number of cases which had seriously gone wrong with some of the naval shipping. So USS Theodore Roosevelt, which had an outbreak, remembering this was early on when the outbreaks were. So the first 3 cases were reported back in March. By May, that had almost over 1,100 cases, and the ship itself was out of action. Now, the captain, who had tried to do the right thing, Captain Crozier, had tried to evacuate the ship. That wasn't supported by the command at the time, and he was relieved of his command. And that is still running. That story is still running out. In France, Charles de Gaulle, another aircraft carrier, by 18th of April, it had over nearly half of its people were infected. So we saw that. In the ADF, we've had, fortunately, a better experience. So we've worked closely with the Royal Australian Navy to clear them as the ships have gone in, but they put very good arrangements in early on, and that allowed. Now, what it meant was that didn't get off the ship in foreign ports. They had very good arrangements, but we didn't see any outbreaks of disease. We worked with the SASR when we still had borders being closed late last year, to make sure their selection course could go ahead, that people could be quarantined and could go ahead with a selection course. And we've more recently worked with the Pacific Patrol Boat Project to ensure that people coming from the Pacific to pick up patrol boats and undertake training could occur, but to be done in a safe way. So it has worked out well, and there's been very close links with the states and territories, probably far closer than previously. We have, the next part is around the vital relationships. Obviously, as the Chief Health Officer, I can't make all the decisions. I need good leadership, and it's around having that distributed leadership, that role clarity, and that freedom of action. So my Deputy Chief Health Officers do exactly that. They run the State Health Incident Coordination Centre, they run the Public Health Emergency Operating Centre. And you have to obviously have the right people in the right roles. And a number of times we've had to move people into different roles to make sure that we actually have the right people. And in fact, for example, my State Health Incident Coordinator was one of the chief executives for one of our area health services, a very senior, very experienced person. But again, we have to develop those key relationships, often at a far deeper level than we've ever done before, and this becomes important as we worked through the 15 months or so of managing this pandemic. I also have spent a lot of time with our legal teams because of the state of emergency and the High Court case, and the communications has become critical going forward. This is for, part of this is obviously dealing with the politics, the media and the general public. It's crucial to keep people informed. It's obviously, we had to work with the media, and they've been very beneficial. Whilst we've obviously had criticisms at times, it becomes critical as part of these roles in managing conflict to make sure that that is very much factored in. We expect everything to be examined. We expect to be as transparent as we can be. I'm always reminded of the 3 stages of disaster communications. That's largely what's happened, what are you doing about it? And then the 3rd stage is invariably who's to blame. We've had to deal with some interesting conspiracy theories, interesting fake news, and that's things like microchipping vaccines, some very interesting ways the coronaviruses have been caused, including linking it to linking it to 5G rollouts and things like that. And then we've had to deal with people who haven't behaved well and have had to involve police where people breaching quarantine and doing the wrong thing. But generally, the general public has come along with us, and that's worked out well. What I've said here is why I don't like running marathons, because this has been probably an ultra marathon. It has been non-relenting. It's been going on for a long time, and obviously as part of the resilience piece, we need to be looking after our staff. Actually, we often do far better with our junior staff, rostering them off, getting them leave, than our senior staff. And we've had a few senior staff who we've had to push to take a break, but we all operate better after we've had some downtime. But we have to, this is around pacing yourself. It's not around dealing with the 2 or 3. And I think this has got some very similar parallels to how we would, be involved in a conflict, and we need to think about these things going forward. Obviously, how do we support people, and how do we give people some downtime on what actually works for them? We are under constant review. It's, as I've said in this cartoon, it's actually it's all we ever talk about. We're subject to national and state reviews, and I'm sure this will be ongoing for years to come. But we obviously have new challenges coming up, and most of those that we have to be looking at from a strategic point of view is how do we roll out our vaccines? What do we do about our international borders? How do we open up society? What is COVID normal going to be in 2021, 2022 and beyond? The next phase has obviously been our rollout of the COVID-19 vaccination program. As you're aware, there's 2 vaccines, the Pfizer-BioNTech vaccine and the Oxford-AstraZeneca vaccine. Slightly different, one's a messenger RNA, one's a viral vector. A lot harder to handle the Pfizer vaccine because of the storage requirements, but there are other advantages. We've also, the Australian will be making the AstraZeneca, or is making the AstraZeneca vaccine, and that'll mean that we get a lot more supply. As of yesterday, these are the figures. We're up to 474,000 across the country. In WA, it's around 50,000. So similar. We generally about 10%. So it is progressing. This is the national rollout strategy. You'll be aware of Phase 1A and Phase 1B. We're now in Phase 1B, so we're already working on our elderly over 70, the Aboriginal and Torres Strait Islanders over 55, and younger adults with underlying medical conditions. And probably by mid-year, we'll get into Phase 2A, which is those over 50 and other critical and high-risk workers. So things are progressing. It has been a little slow taking up, but we are progressing now, and I think it'll pick up now as the supplies of the AstraZeneca improve over the next couple of weeks. This gives you an idea of where we have responsibility. We're obviously very focused on our frontline health people and our critical and high-risk workers, where the Commonwealth has responsibility for some of the other groups, although we would anticipate we will be assisting them. One of the questions is around the vaccine and its safety. The vaccine safety database is huge. We've now seen over 53 million doses in the US, multiple millions of, tens of millions of doses of the AstraZeneca in the UK. Look, there are some adverse events. Most people get a sore arm and feel a bit unwell after both vaccines. Some vaccines are worse than others, but they are highly effective. So this is some of the research from Scotland that shows that these vaccines prevent up to 95% of hospital admissions. And that's really critical to know, is that these vaccines actually work and they prevent you from ending up in hospital. And to be honest, at the end of the day, most of us won't mind a small infection, but we will be unhappy if we end up with a serious infection. So in summary, this is my overview of the leadership and resilience in crisis. That the studies in this area are certainly underdone. Most of the leadership literature is very much organisational rather than crisis focused. We learned a lot of painful lessons along the way, but that should help us to guide sort of our leadership and resilience in the future. And these lessons remain relevant for the next stages as well.
Well, it's my pleasure and privilege to say thank you to Andy. I think my first comment is what a tour de force that Andy presented to us. The amount of time, energy and thought that has gone into the summaries, the PowerPoints, the commentaries that Andy has provided us, could I just react personally and say I really enjoyed following the story and listening to your experience-based advice. I think that Andy has been in a very unique position to talk to us about his many-hatted roles of having to be responsible internally within Western Australia, having to liaise with other agencies, for example the Commonwealth, having to assist some defence units, the references, for example, to the American experience, the French experience, and then the local experiences of assisting the Navy, the SAS Regiment, and the Pacific Patrol Boat Program. I hope that you, as I was, were impressed by the range of examples and the breadth of coverage. There is just simply so much in Andy's presentation that although I've picked a couple of issues out, it's really so content rich that could I be so bold as to suggest to Andy, as perhaps a fellow academic or a potential academic, you probably got the basis of a really good textbook there, Andy, and I think that there'd be every justification in suggesting could you go to that effort to produce it. But here are just a couple of reactions that occurred to me. Firstly, Andy's comment how little current literature and thinking focuses on the actual solving of a medical or typical crisis, rather than a lot of writing about the best ways to organise leadership in organisations, for example. And to some degree, it's a very salutary lesson that what's the purpose of our leadership thinking. Another big point that simply resonated with me was Andy's view that his practical leadership depended on his willingness to accept that his decision making was about risk taking, and that to a very large degree your risk appetite profile will really change or reinforce the ways that you dissolve or attempt to solve a crisis, and also the ways that people respond as such. I particularly enjoyed his metaphor, if you like, that in effect he'd just run a marathon. Part of his role was to support his staff. Part of his role was to make sure that his staff didn't burn out. In short, there's just so much really good material there that all I can do is to just thank Andy very much for the great depth of coverage that he has offered us this afternoon. Now, in our series of improving resilience with the defence and security studies, could I just say that there are just so many obvious implications that we're going to have to deal with quite soon as we move into what Andy described as the post-vaccinated COVID world. An obvious challenge for the ADF is to what degree will it be tasked to assist our close neighbours like Papua New Guinea. If that's the case, what policies will it work under? What legal structures will it work under? Will it have the right to insist that serving people be vaccinated? There are just so many very practical issues that we're going to have to work through as we move into this post-COVID vaccinated world. Again, it's my privilege to thank Andy, to just most sincerely say what an excellent, content-rich, helpful presentation, and we really appreciate the effort, time and thought that you have put into what we've all just been able to share. As I finish, could I remind all of our viewers that this is part of a series, and that our April 2021 lecturer is the New South Wales Resilience Commissioner, Mr. Shane Fitzsimmons. And although this is being recorded in late March 2021, I'm still optimistic that we will have moved in our post-COVID vaccinated world to the point where that can be the first of our resuming of face-to-face lectures in the Anzac Memorial in Hyde Park in Sydney. But as we've all learnt through COVID, one of the real benefits of COVID is it's taught us that we can share this experience electronically almost anywhere. And could I just acknowledge once again that Andy gave us that presentation from Perth in Western Australia. Could I finish by again most sincerely thanking Dr. Andy Robertson for his March 2021 resilience lecture, and could I thank all of you for watching.